colleagues. So we are going to start now with our session, with our workshop session on power of partnerships in global health. And first of all, dear panelists, dear global health colleagues in the auditorium, dear colleagues online, thank you very much for joining this session. And please allow me to introduce briefly myself. My name is Christoph Bayer from the Ministry of Health here in Germany, and I'm head of the Division for International Health Security and Crisis Management. Today's workshop is part of the policy track. Maybe you have already heard of the policy tracks, which we are having here at the World Health Summit. This policy track is initiated by our ministry, and it includes in total 10 sessions. And with the policy track, our aim is to bring debate from governing bodies to Berlin, making it accessible to the global health community. And we as the Federal Ministry of Health look forward to gaining new insights on matters relevant to policymakers from all of you. In turn, we hope to feed these new insights back into our future work on policy making and political processes. Coming back now to our session, The Power of Partnership in Global Health Protection. We host this workshop today because we are convinced that long-term cooperations and capacity buildings are key for global health protection. This becomes even more true after the experience of COVID-19 pandemic. But of course, not only COVID-19 pandemic. I mean, we have heard it today already several times. A couple of years ago, everybody was discussing the case of Ebola. Now everybody is discussing the case of COVID-19. I'm pretty sure next pandemic will come and it will be different again. However, anyway, we believe in the overarching value of long-term technical and political partnership, which goes beyond the sole, let's say, classical project implementation. And the Global Health Protection Program of the German Federal Ministry of Health, which is part of this discussion today and which should inspire this discussion today as well, was established in 2016 and is aiming exactly at these goals of long-term partnership, which go beyond classical project implementation. We worked hard to persuade the parliament to fund this program with taxpayers' money. And I'm honest, it took us several years and we started almost, let's say 9 or 8 years ago. But we are confident that we are living up to this trust and that the money is well invested. At the core of the Global Health Protection Program activities is, as already said, cooperations with national and regional public health institutions, and mainly through twinning project, which we are trying to bring in our, let's say, and I'm proud of this, high-ranking institutional and very specific expertise from governmental or mainly or substantially governmental funded public health institutions. These institutions include, for example, the Robert Koch Institute, the Friedrich Loeffler Institute, which is our animal health institute, our public health animal institute, but of course other institutes which, for example, deal with regulatory affairs, which is the Federal Institute on Vaccines and Biomedicine, the Federal Institute for Drug and Medical Devices, the Bernhard Nocht Institute for Tropical Medicine, the Lung Center of the Leibniz Foundation, and so on and so on. So there are as well some others. So why we think our program was quite successful by now and might even perhaps in the future serve as an example, as a good example, we would like to learn of your experience, attitudes and recommendations for these kind of partnerships to enhance public health protection globally. Today, we would like to engage into further dialogue with all of you. Therefore, let me stress that this is an interactive session where you can participate into the Slido survey. I think you have already learned about the Slido survey today. But you have also the possibility to ask questions in the chat. Now, I don't see the panelists or the other colleagues anymore on the screen. I hope this is not a bad sign, but I continue. If there's a disruption, no, okay. Finally, so coming to an end from my side, let me underline my deepest gratitude to all the speakers for accepting our invitation. A special thanks also to our co-chairs, Ms. Professor Johanna Hannefeld, which is head of the Center for Global Health Protection at the Robert Koch Institute, and the Honorable Director of the African CDC, Mr. John Nkangazong, for helping us to get the most out of today's session. I stop here and I'm now happy to hand over to you, the chairs.
Thank you so much, Dr. Bayer, and a good afternoon from Berlin. Also from my side, it's my great pleasure to be co-chairing this session. The topic is close to my heart. Christoph Bayer mentioned I had the Center for International Health Protection at the RKI, which was created in the aftermath of the Ebola virus disease outbreak in West Africa 2014 to 16, and works to strengthen international health protection through strengthening public health infrastructures. And the COVID-19 pandemic has really meant and continues to mean that we're dependent on our partnerships unlike never before, be it around the sharing of initial knowledge of the characteristics and the epidemiology of the virus, of its evolution, or of the effectiveness of public health measures to contain the spread of COVID. We have depended on our partnership old and new. With unprecedented challenges have come unprecedented opportunities. So today it is my very great pleasure to co-chair this panel with John Nkongosong, who has been really such a crucial figure leading us in the COVID-19 response. And from a personal perspective also, when I say new partnerships for us at the RKI, the partnership with the Africa CDC that has developed during the pandemic has certainly been crucial. So Dr. Bayer has already mentioned, we invite you all, be it in the room or be it in the virtual room, to join our discussion as we move along. But I'm going to start off by asking the first member of our panel, Professor Elena Legido Quigley from the University of Singapore. When we think about international cooperations during this crisis, what was missing and what worked?
Okay, thank you for the question, Dr. Hannaford. So I think I'm going to speak from the point of view of an academic, and also from the fact that I was lucky to be involved in the independent panel for pandemic preparedness and response. And I was responsible for looking at the responses in 28 countries. So it was not an easy task to conduct this work. We did it over the 9 months, and we looked at countries all over the world. And one of the key aspects that we realized, and I think today we're going to see examples of collaborations, but our participants, I was honored to interview on an anonymous basis with experts in 28 countries. And I think the overwhelming response, although we've seen exceptions, I think RKI highlighted as one of the exceptions of good examples, I have to admit, not because I'm here today, but it's very crucial, and it was key, the fact that there was very little cross-border collaboration. And this is a key message that came in our report also, and that we need to find new mechanisms to enhance this type of collaborations. And one key aspect that also emerged was the fact that expertise, and some countries had already previous experience. I remember I was asked to write a paper for the BMJ only a few months ago, and they were like, oh, we've realized that some other countries had huge pandemic preparedness plans and were already prepared and had systems in place. Can you write an article for us on that? That was a year ago. It's like suddenly they realized that there were other countries that they already had previous experience. And I was like, yeah, maybe we can focus on Singapore, we can focus on Hong Kong, we can focus on South Korea, but we could also focus perhaps on Liberia, on Nigeria. So I think they taught us a lesson, African countries and Asian countries, that they were better prepared than European countries. And I think I can say that because I come from Spain, a country that was not very well prepared and that did not engage in cross-border collaboration at all. So I think there's a lesson there to be learned. The second point is from an academic point of view. We've seen that not all sciences and not all partnerships work together very well. And by that, I mean that I think at the beginning of the pandemic, there was all this idea of modelers, of a very quantitative research being prioritized in many countries. And we suddenly forgot about public health expertise on the ground, about health systems research, about behavioral sciences. And I think COVID-19 has taught us that we all need to work together because it's a very complex issue. And we have forgotten a lot about the risk communication, behavioral sciences, and the importance of understanding softer components such as the issue of trust. So I think I'll leave it there, and we can talk a bit more about solutions afterwards.
Thank you so much, Elena. And I'm going to go to one of our virtual participants and ask the same question. Emma, from your experience, what do you think in terms of the COVID pandemic? What were the key partnerships? What was there and what was missing? We cannot hear you at the moment.
I'm sorry. Good afternoon and good morning, everybody. I am gonna speak from the perspective of a manager, a health manager and a person who supports governments working for the Inter-American Development Bank in to improve their systems. In this case, talking about COVID-19 and the excellence in developing partnership. I think what for us in our region was missing, or it was limited, is the issue of governance of the whole crisis management has been one of the biggest challenge. And in general, in these partnerships, we have seen through the pandemic and in other experiences as well, each organization or partnership is accountable to its own governance system. And this is something we need to rethink and revisit, not only for pandemic in public health emergency crisis, but in general, when talking about the health sector and the international cooperation. For me, it is always troublesome in a way that in most partnerships, donors, sponsors, technical global partners are and represent a governance body, the decision-making side. And the countries, in most of the cases, are not represented there, but in some way are accountable for the actions that they are supposed to be implementing. And we even refer to countries as beneficiary and participants when they are not only financial, but also executors of all policies and implementation of those activities. Other issue that I think it was a big challenge is that the small countries, and I am double seeing from Latin America, low and middle income countries had troubles negotiating the contracts and agreements for vaccinations. The asymmetry of information and power and didn't help that to this extent. And some didn't have the competencies and experience to do this. And also in a pandemic like this, it's necessary, and we could see one of the good things is how technology and data collection, was quicker than in other events. But it is important to acknowledge that in pandemic like this, a different type of evaluation and data collection needs to take place. For example, looking at more this kind of approach, iterative approaches, to have information that could feed in a quicker way the decision making, and also telling decision makers how to correct or how to change the approaches and the strategies. And I think those are part of the discussions that we still need to be, need to be improved.
Thank you so much, Emma. Really important points about accountability at national level, also the power asymmetries. And I'm going to go back to the room. Professor Mettenleiter, from your experience, what expertise in international cooperations are important during a crisis, and what worked, what was missing?
Yeah, thank you very much. I mean, I'm a little bit of an outsider. First of all, we are a late newcomer, hopefully not a too late comer for this in this global health protection program, which is actually financed by the Ministry of Health, which correctly is the Ministry of Human Health. So I'm a representative of a research institute that deals with animal health, and that pretty much favors, One Health approaches. And we heard about this One Health approach quite frequently at this World Health Summit before. So I think, the important issue then that we have is, first of all, it's not trivial for a national authority in Germany, like the Robert Koch Institute or the Friedrich Loeffler Institute, to be actually active at a global scale. So, our design is nationally oriented, but I think, we all learned the lesson even before COVID-19 that, infectious diseases don't represent borders. AMR doesn't represent borders. So, it's basically a logical development that we now even have the legal mandate, both organizations here, in terms of deployment of our staff, also abroad for capacity building. And of course, it also applies to the other institutions that are part of this global health protection program. but I still want to make that point that I mean the accession of FLI to that program not that long ago, I mean brought this additional part of. It's not really One Health. I mean, it's still one medicine, but at least the animal side into this picture as well. And I mean, we've seen that. I mean, not only with COVID-19, which I mean originates from animals. I mean, I'm a trained biologist. I mean, it doesn't really make a difference anyway. I mean, we are part of the animal kingdom as well. So I mean, for a virus, I mean, this is no real barrier. So I mean, this is one of the issues. And the second is, I mean, of course, we have more. I mean, we had more in terms of zoonotic infections before. We had pandemics before. I mean, we know that many of them actually, I mean, originate from animals, be they domestic, be they wildlife. So I think, I mean, this is an essential component if we think about a global system of combating, I mean, this particular kind of threat. And it's not only zoonotic infections. I mentioned it before. I mean, going back to 3 or 4 years, I mean, everybody talked about AMR, and actually zoonotic infections were not taken, I have to say, probably in some areas of the world that seriously, definitely in this part of the world. Now this has changed after the COVID-19 situation, and it's more like a situation at the moment that I say, don't forget AMR. But of course, I mean, both are inherent parts of this One Health approach. And I think, I mean, this is the important issue. And that's why I'm quite glad that FLI joined the Global Health Protection Program, and also that FLI, also just like Robert Koch Institute, was also able to create a new unit, International Animal Health / One Health, which is specifically created for, I mean, this outreach and this, I mean, capacity building / I like the words support better, because I mean, this basically is something that goes in both directions, and also learning in both directions. Thank you.
Thank you so much. So not only do we need partnership across borders, we also need partnership across disciplines. And I'm going to move to a completely different area of the world again, to the West Balkans. So we've got Silvia Bino with us from our sister institute, the National Public Health Institute in Albania. Silvia, from your experience of the crisis, what aspects are important? What kind of aspects in a crisis are important? What worked? What was missing?
I think because we had a collaboration, it's important to have in place before a collaboration, whatever it is. And from our experience, it is trust and credibility among all the partners that strengthen more the partnership. And between Western Balkans, lots of countries, we had a partnership before. And during the crisis, this partnership has been strengthened. And we have seen what kind of issues we have to tackle. And since the beginning of the pandemic, even through Robert Koch Institute or other partners that we had in the region, like CDC in Atlanta, we had to organize and to share our experience for every answer to the pandemic, response of the pandemic. For example, we shared experiences about lockdowns, how the population has faced. We shared the experience in general for public health about necessity of testing, because there were different opinions about it in all countries, about contact tracing and how to organize training on contact tracing within different countries in the region. So I have to say that trust and credibility that we had among ourselves, but also with international partners, helped us to better respond to the pandemic. Because in the beginning, you don't know many things. And this was true for public health, but I would say that for treatment and for patient management, this was not so strong. Maybe we had a lack in partnership within this area. So we had to wait for other international organizations like WHO or the others to organize things like this. But those were a little bit later compared to whatever we had for public health response. So I would say from the perspective of Western Balkan countries, I saw COVID-19 as a possibility to strengthen the partnership that was in place. And even the people were overloaded with daily tasks. They were aiming to learn more and to compare themselves, how they are doing their work, or to compare, or to improve, or to share best experiences, etc. So even without meeting face to face, even the digital, and using a kind of agile approach, without a fixed timing, let's say, we were able to share and keep our partnership and the partnership that we had before helped.
Yeah, thank you. Lots of very interesting points. And I think we've all, or certainly this is my shared experience, every time we have had an exchange in the epidemic, we've learned so much. So I'm going to come to another partner and Tochi Okwa in Nigeria CDC. You've also been in the middle of the pandemic. We wished we could have welcomed you here in Berlin, but we're delighted to be seeing you looking well on the screen. So let me put the same question to you in terms of responses during an international crisis. What's important for you? What worked? What was missing?
Thank you very much, Johanna and colleagues. I'll share my perspective from the point of view of somebody who is involved in responding in the area of infection prevention and control in my country, Nigeria, and also providing some leadership at the continental level at the Africa CDC Infection Prevention and Control Technical Working Group. First, as has been said here, information sharing is very important about the unfolding epidemiology of what for now in COVID is a novel virus, information around the patterns of transmission, the efficacy of various methods of prevention, and specifically for us that had to deal with infection prevention and control, the best ways, what had worked, what hadn't worked in those countries that had a head start in dealing with the pandemic. And we found this very useful because it offered us important lessons and best practices, even at the very early aspects of this pandemic. For instance, we got a head start immediately that we needed to pay close attention to healthcare workers because of the information coming out from the other parts of the world. So for us in Nigeria, for instance, it was very useful. We were able to develop the very, very initial draft of guideline documents with initial materials that were coming out from China, from our European partners, and what have you. So it gave us some confidence that we were starting in a place that wasn't just ground zero. And it helped us also to leapfrog our response. So that we found a very useful part of what happened during this pandemic. I'll speak about something that's very dear to my heart, and that is the value of systems that were built ahead of the pandemic as part of the health system strengthening. So the cooperation that we already had in place before the pandemic that was actually focused on making our health system more resilient. And this became critical during the COVID because the usual foreign expatriates that will be sent to less endowed parts of the world to support them when they had different outbreaks, we are no longer available to provide them such support. And because everybody had gone on to help their own countries and even movement was largely limited. People then had to rely on local human resource and systems that they had already built. And I'll mention specifically for Nigeria 2 examples where the systems we built ahead of the pandemic became the anchor of our infection prevention and control response. One of them is the investments we made in establishing a national infection prevention and control program in Nigeria, the Turn Nigeria Orange program, with the collaboration with the US CDC. And then the second one is the Nigeria Capacity Development for Infectious Diseases, the NICAID IPC sub-project. This NICAID IPC sub-project is really funded by the German Ministry of Health and is implemented by the Nigeria Center for Disease Control with the support from Robert Koch Institute. And what we were really doing was building the system through human capacity in the area of infection prevention and control. And we had developed a unique training approach that we felt would bring about quality change in infection prevention and control in health facilities. And that was where we were, just getting these things ready. But the most important thing about this program was it was keyed into the overall strategic plan for infection prevention and control in the country. It was fully keyed into even the antimicrobial resistance work that we are doing in the country. And then when COVID-19 came, the human resource we had built, the capacity we had built in the NICAID IPC trainings, they were ready. Even though we weren't getting them ready for a pandemic, we are getting them ready to make the health system resilient to take whatever shocks that will come, but more importantly, to provide good quality routine care for Nigerians. That was what we are getting them ready through this cooperation. But then when COVID-19 came, they were very ready, and we are the first set of people we sent to the various hotspots states in the country as part of the rapid response team. And the work they did formed the basis for the establishment of infection prevention and control in many states in Nigeria. And it also became the material, because of the nature of their training, they were able to support in developing infection prevention and control training materials, which till today, we are still using it for our national IPC training. And that's why I say this is close to my heart, because it shows the value of cooperation, an international cooperation that is focused on building a strong health system. Then I'll just mention another second one before I end my, the regional cooperation. For Africa, the COVID-19 pandemic highlighted the need for greater regional integration and stronger collaboration between countries in the continent. And this continental cooperation was championed by the Africa CDC through the AFCON. And I'll speak specifically about the Infection Prevention and Control Technical Working Group, which I'm honored to serve as co-chair. It provided us a clear example of what can be achieved when people with a common background and similar challenges come together with the mindset of overcoming common challenges using local resources. So it provided platform for getting donations into the continent and helping countries who normally would not have the capacity to do that for themselves. An example is the medical supplies from Jack Ma Foundation, which was part of the initial things that supported member states during a time of extreme PPE shortage in the world. And also to address, again, the urgent need to boost local capacity production to meet the continent's PPE needs. The IPC Technical Working Group convened immediately a high-level workshop to begin to bring local producers of personal protective equipment in the continent. And this work is still going on, and I suspect that it is already leading to a very high-level strategy at the Africa CDC to ensure that lessons learned from this pandemic would help the continent moving forward. And I'll just wrap up with what was missing. One of the key things I was missing is it appeared to me that there was this general lack of understanding of the value of infection prevention and control. Mm-hmm. Other than those of us that are tasked with infection prevention and control in the response, we had to deal with IPC usually not being the priority of both funders and generally leaders is often ignored. And we had to constantly justify the value of infection prevention and control and why it should be funded. So maybe I'm putting it on the table now that it is time that we relook at the things we prioritize. Surveillance is good, lab testing is good, case management is good, but we must realize that why we have numbers to count and diagnosis to make is because infection is moving from one person to the other. So in my mind, it's a paradox that IPC is usually not given the position it deserves. Thank you.
Thank you so much, Tochi. So many important points, pre-existing partnerships, the regional cooperation, but also the importance of IPC in focusing on prevention. Thank you. I think some very strong points coming out of that first round. John, I'm going to hand over to you in a moment, but I've got some results here from, so we had the interaction with the audience and we asked the similar questions into the virtual room, into the real room here, partnerships in global health during and after COVID-19, although when it will be after, I don't yet know. What is the biggest challenge? And the first thing that comes out in the poll is limited connection between a crisis response and longer-term system strengthening. And it's almost as if they heard Tochi as she was talking when they were pressing that. And then in joint second place is the short funding cycles and the lack of an interdisciplinary or a One Health approach, lack of community engagement also cited. And then some other factors. So that's just to give a brief input. John, I think it's over to you for the next rounds of questions. And again, an honor to be here with you in the virtual space. Over to Addis.
Thank you so much, and greetings from Addis Ababa. Joanna, good to see you, and so pleased to have been asked to be part of this very exciting panel. I've actually enjoyed the conversation so much. So let me take us to the next round of questions and hear what people think, the panel think about the opportunities for sustainable cooperation that you see as a result of this pandemic. The pandemic has generated a lot of opportunities, has also exposed some limitations. So I think that is extremely valuable. So we'll start again with the same order, and starting with Sylvia, if you can just briefly share your thoughts and views on what you believe are the opportunities for sustainable cooperation that are going forward. I think before I open the floor for the panelists, a lot happened during this pandemic very early on. It was remarkable that sequences of this virus was obtained just in a couple of weeks. It was remarkable that diagnostics were developed in a couple of weeks, not months. It was remarkable that vaccines were developed and put into people's arms within 1 year. Very, very unprecedented. I always amuse myself by saying that for those who, if you brought back those who were unfortunate to fight the Spanish flu pandemic in 1918, today here, they would look at us with total amazement. I mean, of what science has done, because those folks fought the pandemic in 1918 with probably nothing, okay, and really nothing. They were infection prevention measures and social distances, as Tochi has mentioned. But they will be very, very amazed that they didn't even know what they were dealing with until 1930, when they could identify the virus that was disseminating the population. The continent of Africa, about 2% of its population died at that time. The population of that time was 130 million. Today, we are very fortunate that cooperation has existed. There are gaps, and I'm sure we'll get to discuss that during this very important roundtable. But without further ado, let Sylvia please get us started with this very important question, Sylvia, on opportunities for sustainable cooperation that you see as a result of this pandemic. Over to you.
Thank you. I mentioned before that we saw the pandemic as something that will bring us some opportunities. And opportunities link within the control of the pandemic itself. Then it included a lot of opportunities in terms to include all laboratories, let's say, One Health laboratories in our region for diagnostics, for sequencing, etc., that never happened before. And this was an opportunity to strengthen One Health in general. So in the whole region, in our region, we have now a network of One Health laboratories that are contributing to COVID diagnostic and sequencing. So it was the pandemic that brought this kind of opportunity to join forces and for a common enemy, let's say, and strengthen the collaboration that and replace many meetings and many discussions related to One Health. So we have a network of One Health laboratories, as I said, for doing sequencing, and this was one thing. The other thing was related to vaccination. because vaccination brought together different experts of different fields in the region that are members of NITACs, a technical advisory group of experts or not, and coming from different organizations like regulatory agencies, etc. And all together, we had to collaborate to take decisions about different vaccines that were even not approved maybe by FDA or EMA, but what were the benefits of such vaccines for the population. And we are small countries in this region, so we had to look at each other, to each other experts, and also from experts from outside, like from Germany, from US, from ECDC, from WHO, and other countries to participate and to help in taking such decisions in terms of approving vaccines, but also implementing the programs and improving the implementation of the programs in terms of vaccination. So those were two key points that we saw like a possibility that pandemic brought, because we tried before to build One Health during avian influenza, etc. And we had some collaboration, but not this kind of collaboration with fully involvement of all the laboratories and experts, even engagement of all kinds of experts because of lack of resources in each of our countries to be involved in different issues, in data analysis, in contact tracing, etc., etc. So this was an opportunity for bringing people together and making the best of it. And the same it was also for vaccination. We were trying to build a regional group of experts, and we had some discussion, but this was very quick. So we saw a need. And I think during a crisis, you see an immediate need. And if you have a group of experts that they truly want to solve the problem, they improve their collaboration.
No, thank you. Thank you so much. Let me borrow from Joanna's moderation and zigzag around a little bit and go to the room now so that we can hear from Thomas what your views are on this topic. Then we'll go, just pick it from there. So Thomas, please.
Thank you very much. I mean, I'm glad to hear from Sylvia that they actually have a network of One Health laboratories, which is very close to my heart as well. I mean, I think what the COVID-19 really showed is that, I mean, it sounds trivial, but I mean, we need to really break up these silos. We were talking about that for a long time, but I mean, actually, I mean, in the support and the building up of laboratories, I mean, it became very clear that, I mean, the best that we can do is join forces. I mean, beyond the silos. And particularly important, and you mentioned it, Sylvia, is, I mean, the outreach in the veterinary field compared to, I mean, what we've seen in the human medicine field. And there were, I mean, excellent examples at a global scale that this cooperation worked very well from the beginning, and it basically worked very well from the beginning when there was always when there was already an interaction between, I mean, these two portions of the health system or the One Health system before the pandemic started. But I mean, it made it very clear in terms of also the need to have enough competence and enough capacity in particular. I mean, that the combination would just work a lot better. And there are countries, and this is not dependent on any kind of regional aspect, where this worked excellently. And there were other countries, and it's also independent of the region, where, I mean, we realized that we still have a very long way to go. I mean, to actually combine these forces the way we want to have that in a One Medicine / One Health approach. And that's what I meant when I said beforehand, I mean, it goes in both directions. And I think, I mean, even here in this country, we can learn a lot, I mean, from some of the approaches, these exemplary approaches that have been taken, I mean, as quite normal in other areas of the world and in other countries, in the combination of these two sectors. Perhaps we should even stop, I mean, calling them two different sectors, because in the end, I mean, it's health, and it is this One Health, and I mean, we should take that as one sector. And just as an example here in this country, I mean, it took 2 amendments of the health legislation that veterinarians were officially allowed to do testing for COVID-19. I mean, this is, for me, still something I wouldn't have believed beforehand, but this also symbolizes that we still have a long way to go. And I'm just happy to hear that you are ahead in this particular instance, and we hope that we're going to have a network of One Health laboratories, basically not only in particular regions, but a global network. And this is, I think, what this Global Health Protection program can also help to achieve. I mean, this networking. And I mean, the same is also true for this One Health high-level expert panel that I'm also kind of representing here, because I mean, this is what we're looking forward to. We want to have an integrated surveillance, monitoring, and competence network that basically includes all the capacity that we have. And I mean, it's also not trivial, but I think it's a rather low-hanging fruit because I mean, we need to link networks that are already there, which is not trivial, but I think it's worthwhile going for it, because I mean, this will give an added value for all the different partners.
No, wonderful. So I think let's keep the ball rolling. Maybe what we should do is just stay in the room for 1 second and take and listen to Helena, what your thoughts are on this question. Then we go out of the room and go worldwide. So Helena, what are your views on this? That is your thoughts on opportunities for sustainable cooperation that have emerged from the pandemic that we are currently dealing with.
Thank you, John. So me being an academic and providing the academic perspective, for us is a huge opportunity to collaborate with the governments, mainly because for once, evidence became the buzzword for all governments all over the world. So they were all saying we're basing policies on evidence. And for us was music to the ears, because I have to acknowledge that those that we do research in this area, we actually never thought it was quite straightforward. And we actually even have a theory that is called the 2 communities model, whereby governments live in one world and academia lives in another world. And why is that? It's because we have different incentives. So academics, we are not paid or promoted by how much influence we have on policy, but by how many Lancet papers we publish, how much money we bring. And I think this is also very important to acknowledge, and to say that COVID has brought us much more together and has also realized that, of course, public health experts, I'm exaggerating a bit here, we all want to influence policy, but it has made it much more clear that we need to work together. Now, doing the review that I mentioned on 28 countries, we saw different models. Like some countries were struggling on how to rely on experts for providing policies in terms of the response. So some created expert committees. Some were lucky enough to have previous institutions, public health agencies, but not all countries. But what it became very clear was the need to have transparency and to have independence. That's what the population asked for, and some countries succeeded and some others didn't. An example of a country that did not have the structures but established a committee in Uruguay with scientists that they were reporting directly to the prime minister, and that they were giving transparent information and they were making the minutes public. Then you have other countries that didn't start very well, like SAGE in the UK, but then it became better. And then you have countries that they had experts and they were giving press conferences and they were linked to public health institutes. I think what we need to think now is what type of model do we want looking into the future? And a lot of countries are looking now into developing their own public health agencies. This is a new ask, for example, in Spain. And now I think the area to discuss is which model is the most ideal. So we're looking at RKI in Spain, just to let you know. They're looking at Public Health England. Unfortunately, Public Health England, perhaps it was too independent. So I think it's being dismantled. So we need to think of what agencies do we really want? And one final point I wanted to make was also, okay, I've given you the view of governments with academics, but also very important communities. We haven't mentioned the word yet here in our discussion. How do we engage communities much more in policy implementation, but not only that, on transforming our health systems? And we've seen that the countries that they've been more successful in managing the response, they had community health workers. And this was much more prevalent, again, in Asia and in Africa. So a lot of European countries to learn from that. Do we have community health workers? We don't really have a network like in Thailand of 1 million community health workers that they were able to implement policies. When I mean community involvement, it's not this tokenistic approach. We really need to think through structurally how we're going to fund that and how we're going to involve the community and listen to them. Because particularly for risk communication, we completely forgot in Europe to involve the community, and we suffered from that. To give you an example, in Spain, we did not develop strategies thinking of the youth, thinking of the vulnerable groups. We did not listen to them. We developed strategies without involving them in focus groups, without asking them, what do you actually want? I mean, I was talking to the youth and they were like, why nobody asked us policies that we will follow? And instead, they're not listening to the policies. They are partying on the streets, but they really want to commit, but we don't listen to them. So these are some of the areas that I think we need to reconsider. And what we call now in academic terms is co-production of knowledge, involving the community in the planning of services, but also in making the decisions themselves.
Wonderful, Helena. You touch on some extremely important key aspects from this pandemic that might save us going forward. The concept of enabling every country to have their own national public health institute. I mean, a good example is for Africa is what the Nigeria CDC has done. It has demonstrated that if enabled, Nigeria CDC is just 5 to 6 years old, but demonstrated that if supported properly with good leadership, like what Dr. Chikwe demonstrated in Nigeria, you can truly become instrumental in managing a pandemic, even with very limited resources. I call it the military barracks for fighting pandemics, and that model needs to be sustained. In Africa, we are hoping that, and a vision for Africa CDC is all 55 member states should have that. You touched on community healthcare workers. We did deploy 18,000 community healthcare workers as for Africa CDC to supporting member states. Those are some very, very valuable lessons. Let's leave the hall now and I'll go to Tochi. I mean, since you spoke last, I don't want you to be last. I want you to, take the floor, share your reflections on this sustainability, then we go to Emma.
Thank you. Thank you very much, John. And I'll say that everything colleagues have already said are already part of what I will also suggest for sustainable cooperation. But one phrase that became a cliche during this pandemic was that we are building the ship while we are sailing it. It was one phrase I heard one too many times in this pandemic. And what that in my mind was basically speaking to an unprepared system that was now forced to operate. And as I reflect on that and sustainable cooperation, I think if we can make a ship that isn't ready to sail, when we have time in peace, use the word in peacetime, if we are looking for what to make sustainable, then we should make those investments in those aspects that actually strengthen and make the systems resilient. As difficult as this might appear, COVID-19 has actually shown us that even the countries we consider weak with very poor systems, if they are allowed to stand on their own, as COVID-19 forced so many countries to do, they were able to, at least, even if it was on very shaky legs, they were able to do some standing. So I'm saying that sustainable cooperation should look deeper into those aspects of health system that need a lot of hard work, but we must begin to do that hard work. And that will get me into the second part, which is the human resource for health. And when I talk about human resource for health, I mean a well-organized, well-thought-out human resource planning for health that takes into consideration the peculiarities of individual countries and not a one-size-fits-all. It's been mentioned here the value that community health workers have played in this outbreak. And that shows that we need quality people who can be trained and who will become engaged professionally, contributing towards health security. And often we'll realize that part of this human resource for health would also involve planning clear career trajectories for health workers, especially those ones that will be involved in those aspects of the health system, the preparedness and the response aspects. During a crisis such as this, we turn a lot of people into the human beings we need for the response. We turn a lot of people into disease detectives in the form, a lot of epidemiologists get into the aspect of field epidemiology. We get a lot of people trained and build their capacity in infection prevention and control. We get a lot of people build their capacity in case management for highly infectious diseases. And they get excited, they get ready. But when these outbreaks wane, because there's no clear planning to continue to engage them and meet the need for future, all the enthusiasm, all the self-development that they put into that fizzles out. And that brings me to how much of the human capacity that was built during Ebola came back and we're still relevant and we're still active and engaged during the COVID-19 pandemic. People must be made to see a career path, a clear progression and motivation to continue in those interests that they picked up during the pandemic. And one more thing, we must work to overcome language barriers. This was a very practical situation that came to me as I worked within the West Africa sub-region as we tried to collaborate and support each other. It came as a shock to me that even neighboring countries I could walk across, we couldn't communicate because of language barriers. So something that could be sustained is the building the language capacity of people who will be involved in public health response. And this I'll link into forming network of professionals, at least across regions, who can work across each other's, we can just cross each other's borders and support each other. And perhaps as we work together like that, we can stop some things in country before they cross borders to come in. But language for me, especially in West Africa, is something that we must invest in to build the capacity of each other, to speak each other's language, even if it's at a very, very basic level, a very practical situation that impacted the trainings we did for the continent, where we had beautiful training opportunities, beautiful training packages. But because a lot of the trainers maybe couldn't speak English, a lot of them couldn't speak French, it was difficult to take this beautiful package to all the people that need it. So it's something we have to, if it's possible, pay very good attention and develop that and have a clear strategy for ensuring that neighbors can speak each other's language. Thank you.
No, thank you so much, Tochi. Workforce development is clearly an area that an opportunity for sustained cooperation going forward to not only fight this pandemic, but to fight subsequent pandemics. We just always remember that this pandemic is still with us, so we've not, it's not yet over, so that we don't start talking about the next pandemic. I mean, so excellent points. Let's conclude this round of questions with going back to Emma on this very pertinent question and get your perspective from where you sit.
Thank you. I'd like to share with the audience that only 34% in our region is fully vaccinated. And this percentage, however, goes from Guatemala with 13, Nicaragua 4%, and Chile and Uruguay with 74%. This is a reflection of the inequality and the inequity in access, not only among countries, but probably also within countries. And this is also a reflection of even despite, the best efforts our countries have been doing, the due diligence, this is also a reflection of some of the limitations we still have, and it's an opportunity for new collaboration. So I think there are plenty of chances of establishing new collaborations and new partnerships, especially in countries and low and middle income countries. I think it is not always an issue of financial support, but more importantly, technical assistance, but not any type or any kind of technical assistance. People coming and going out and leaving recommendation, that is something that doesn't work for our countries. And we do need, that daily shoulder to shoulder accompanying the teams, not only at the central level, but as regional and at the subnational and local levels to develop competences. And if this is done, and it should be done before any public health emergency, then we will have resilient health systems to face any crisis and challenges. And in general, we could see that some of the countries had emergency response plans, not only in our region, but globally and at country level. And then why? The question is why we don't get those implemented. And it's a matter of developing plans in emergency and response plans, not only from the programmatic perspective, but also from the managerial aspect of dealing with crisis. Because, you know, how to set a surveillance system or how to treat, have the new protocols for COVID or for any other crisis, those are very programmatic issues. But in general, we also need support on issues on planning, on monitoring, on how to deploy at national levels, how to communicate with the public, how to make sure that the mechanisms for rolling out a vaccine plan are in place, and how to support teams to do that. We have experience in 10 countries out of 26 in Latin America, and that was before the pandemic, where the approach was looking not only at the programmatic issues, but at the health system strengthening issues and supporting the organization of the health networks and the teams, and looking at how the data is used at local levels, for example. So this is really important. And I think as measurement, it should be an intervention. Management should also be an intervention in terms of technical assistance. And that needs financing and also needs time. For example, I know that the Robert Koch Institute, for example, has been supporting at the regional level some issues related to lab and competences and skills on that. And that is really important because I'd like to mention another point here, that probably this approach of sub-regional support can be important. In our region, for example, there are sub-regional councils of ministers, and anything that is approved there is binding, needs to be conducted and implemented and planned by all countries. So there are spaces like this, not necessarily country by country, but through the sub-regional mechanisms to establish new partnerships and collaborations. Another idea I think this is a really important one in terms of how to better align incentives to bring academia and research closer to implementation. For most of the audience here, probably access to publications and innovations might not be a huge challenge. But for our countries, our ministries of health, for example, in Latin America, the staff at the operational, at the policy, and at the operational level is a huge challenge, not only because of connectivity, but as Toshi was saying, also about the language issue. You know, most of the papers are published in English, and the general population is not, cannot speak English, and this is almost a privilege in our countries. So also how to navigate and finding what you need, to look for in terms of innovation and new knowledge, it's not an easy issue. So how to make sure that all the huge amount of research and new knowledge can really be accessible for implementation, from the implementation science point of view, to implementers and to policymakers, to make sure that those research get implemented. And finally, I think in terms of new collaborations and partnership, I think it's important to consider the participation of multilateral banks as the Inter-American Development Bank, not only as financiers, because we can offer expertise in national system organizations and health facilities network structure and functioning, facilitating some national reforms because of our huge portfolio and because our relationship with the ministers of finance, as they are members of our board of directors and our former liaison. So not only for pandemic and crisis, but in general for health system strengthening. And we have seen, for example, this partnership as I was talking about, that was aiming at health system strengthening to decrease maternal and neonatal mortality. In those areas where that partnership has been working in a sustained way during the last 10 years, the crisis was easy to manage because it's not a matter of the issue of the topic, it's a matter of the health system structure and to have the resilience, working on teams and knowing, exercising daily how to use data to improve daily, to tackle the problems and to work together. So those are some ideas in regards to some new ways of collaborating. This sustained way, long-term collaboration, yes, it takes time, longer than other type of collaboration, but it's gonna be more sustainable and will pay off as long as we support countries to develop through the whole system, from central to local levels, including community level, the competencies and skills required. Thank you.
Thank you so much, Emma. Very rich discussion. So let me at this point return it to Joanna to take us to the next series of reflections before we move to the conclusion. Joanna, please, over to you.
So I'm going to, in the interest of time, I'm going to take one question from the floor or from the virtual floor, which asks around what can we do to get away from donor-beneficiary dynamics and partnerships and move to equal collaboration? Maybe a little bit controversial. I'm going to go to Tochi first.
Okay, thank you very much. I think maybe country ownership. When I talk about country ownership, even if donor funding is coming, if an aspect needs to be carried, even if it's the human resource side of the partnership, the human resource side of the collaboration. So it brings me to co-development and planning together. It's a strong factor in collaboration. So if countries, instead of just giving donor funds, are asked to bring their action plans, their national plans, their strategic plans to the table, and what budget and funding they already have in place. And in the discussion on the table, gaps then, donor funding can be brought to fill in gaps. I think this will not only be more sustainable, but it will address what a country has already perceived as their need, has already planned for, and even if it's just the human resource side that are bringing in, while the other implementation aspects of the funds, the partners will have to bring. I think that is one way that we can begin to make countries not to be completely donor dependent.
Okay, and I'm going to put the same question to Sylvia. Donor beneficiary dynamics and partnerships. How can we move to equal collaboration? Is that something that has been part of your experiences over the past 21 months?
I fully agree with Tochi. You have to identify the gaps. You shouldn't have donor overlapping, You have to know where your needs are. And when you really identify your needs, then you have an equal partnership because you share the experience. Even the partner that is collaborating with you or is the donor country, they learn from you. So, and from this implementation of filling the gaps. And for example, we had a very good experience with event-based surveillance with Robert Koch Institute and with some other countries. And we started from the scratch, let's say. And I mean, the Robert Koch Institute had more experience in developing guidelines, etc. But then we advanced through using a partnership among the countries or within the region to identify what were the gaps, for example, within event-based surveillance. I took just an example. And then how you include different partners, not to overlap, but to fill the gaps within one subject and to plan it, to plan the implementation. And you need dedication to do that. If all partners are dedicated, then everybody learns from each other, and there is you enter equal partnership.
Okay, and Elena, I'm going to ask you the same question. So donor beneficiary dynamics, unequal partnerships or equal partnerships, did that come up in the independent panel?
I think I was trying to reflect because I completely agree with the comments made by Sylvia. I think in our case, and more from my experience, is more the partnerships in terms of academia, which of course sometimes they have this donor involvement where academic institutions, they provide funds to the global south. And I think for us, what we've learned also, and this is a bit, I think all institutions now are facing the challenge of also decolonizing global health and decolonizing the global health curriculum. And not only that, it's about transforming their own institutions. So when we look at that, what we've seen, and we published a paper a year before the COVID pandemic, we published a paper on gender and ethnicity equality in academia, top public health institutions. What we found is that none of them were doing very well. So public health top institutions that are supposed to be equitable, gender balance, gender ethnicity, they were not doing well. And the title of our paper was more talk than action, which can lead you to suggest what were, so there was lots of beautiful plans, but issues were not implemented. So I think in that sense, I think all institutions, either donors, academic institutions, where I think, especially those in the north, need to look inside and use this opportunity of COVID to transform the structures, institutions, and also specifically for academic institutions to look at the curriculum and look at decolonizing global health, which is a huge movement now that started before COVID, and now it has escalated the issues much more.
Thank you so much. And John, I'm going to go completely off-road. You're co-chair, but I can't help but ask you that question. Donor beneficiary dynamics during the COVID-19 pandemic, how can we move towards more equal collaboration? Has that happened? I'm really interested in your view.
Well, I was keeping my views because I'm a co-chair, but since you now switch me over to the panelists, I'll be happy to contribute from that perspective. I think, first of all, from where we sit, we appreciate that. I mean, that the donors partnership is very important. The whole concept of a pandemic means all of the people, right? So it means we have to solve it all together. So I think that is central to our understanding of the question. However, I think what we have advocated strongly from where we sit is that this kind of partnership, the donor-recipient partnership, must be built around respect. Okay, what we call respectful partnership that aligns with our priorities. Respectful partnerships that recognizes that the knowledge base is local. You just lack the resources to move that forward. I think that is extremely important. Over the course of this crisis, we have seen, as I think Emma mentioned it, she touched on something that was, I was smiling when she talked about just coming in and going out with solutions that from outside and disregarding those things that already exist in the field. A good public health practice, Emma, is local. Okay, good public health practice is local. The concepts are universal, but the true practice and impact is local. So I think as we move forward, thinking about a partnership, the donor relationship in the sense of respectful partnership for impactful outcomes, recognizing the power of the local institution and capacity, and also recognizing that the only missing gap is the money, that the money part is that if you're a donor sitting somewhere in Europe or United States, what your counterpart in Africa doesn't have is not the knowledge base, is the money that they lack to move this forward, that you come in together on the table. The whole definition of partnership is where two parties come together to cooperate to address a mutual issue of interest. I think, and so in any partnership, they are partners. The partners in partnership must feel comfortable that they are treated respectfully. I think that is the whole concept of which I think Helena talked about, decolonizing, global health, and others. Now, lastly, we cannot leave this debate without reflecting on what has worked for multilateralism and what do we need to do in multilateralism to make it even do better. Because first of all, we have to admit that we all need multilateralism. But from where we sit, I think it is no secret that there's now total distrust from the global south on this multilateral system because they have failed us. I think Emma talked about the numbers of vaccination in I think Latin America. If you hear the numbers in Africa, you fall over your chair. We have a continent of 1.3 billion people with less than 5% of the population vaccinated. Where is the power of multilateralism in that? That is all partnership, right? So I think then the other thing we need to down look at is that where has regionalism functioned? Well, I mean, Tochi touched on what Africa CDC has done with the leadership, the political leadership for the continent. In these challenging times, one thing that needs to be highlighted and has not been done properly is what the political leadership of Africa work with a young organization like Africa CDC to coordinate, cooperate, collaborate, and communicate effectively in managing this crisis at a regional level. Those regional instruments must lend themselves for trusting partnership. Those are instruments that our partners and donors should be supporting, like mechanisms like the AVAT, mechanisms like the African Medicine Supply Platform, mechanisms like a strategy for developing vaccines on the continent, PAM. Those are instruments that have emerged within the region, not from multilateral, but from the region that must be supported by the donors. They're not creating things that would seem very distant from where the action, what I call the theater of response is. That is what is going to give us a pandemic compass going forward to address this pandemic and to address subsequent pandemics.
Thank you so much, John, for that, and apologies for transgressing there and asking your impact. I'm going to put the same question on the I think so many valuable points. I'm going to ask the same question to Emma though, because obviously you're the Inter-American Development Bank, so you are a big donor. How did you address? How do you cope with this dynamic, donor beneficiary in partnerships?
Yeah, the first thing, and we have had experience in 20 countries in our region in terms of trying to stop creating concept not an investment case by ourselves from 35,000 feet, but actually sitting down with countries. And I think Tochi or Silvia were saying, I'm sorry, I don't remember, about understanding the needs and going to the basics again of listening, because we probably think, some of us might think that we already know the problem, but we need this problem, problem-driven iterative approach, understanding that that local context do matter, and also at the beginning was somehow difficult in terms of, as Silvia was saying, building trust and transparent relationship. This is, we need to invest time also in this, discussing openly our agendas and interests, and be transparent about the resources that all of us have in hand and accessible, and how this could be put together to the cost. And also another learning for us is be prompt to discuss problems and how to solve them together, not from this perspective of looking for who's responsible or who's guilty, and then having some old-fashioned punishment way of working, and which is really important because it comes to accountability again. It's not that, that even if we talk about modern management, those kind of issues in the environment in which we work, it could be only making others accountable and not looking at what financiers or central levels of ministries of health or donors are also accountable for. And I think the initial discussion, not bringing ideas, but bringing some resources in technical assistance, potential technical assistance, is the initial discussion, which is really important when we do listen without coming with even, you know, a concept note already prepared on what we think the countries need. I think this is really critical for country ownership, commitment, and sustainability. But to do this, we do need also a strong leadership that allows for this discussion from both sides, and that includes how the feedback loops, you know, are feeding not only from the learnings, but from the failures, how the approaches might change over time, not too long time until evaluations are done, but while implementing. While being implemented the actions. And another issue is the flexibility. The flexibility on budget and management, and how countries together with other partners, internal or external partners, need to have the room and flexibility to change direction, to change budgets, to change metrics of what we are achieving, and stop as well looking at productivity measures. You know, number of people trained, and that doesn't mean anything at the end, because we do need to set with countries and serious discussion at the outcome level indicators, but then provide the room and the resources and the conditions to be flexible and to move around and to use data and to work through the systems, the level of the systems. Over.
Okay, many very practical comments as well. And John, I'll be handing back over to you as my co-chair in a moment for some closing reflections. But before I do that, last but not least, Thomas Wendleiter, I would have asked lessons on these dynamics or avoiding or equal partnerships from the animal health sector, but now you've said we shouldn't call it that. So I say, just from your experience and position, lessons on equal partnerships and overcoming those dynamics. Have you got any insights to share with us?
Yeah, actually, I mean, many of the issues have already been raised and touched. I mean, definitely equal partnership means equal partnership. And I mean, when I hear donor and beneficiary, I mean, I get the feeling this is not really equal. I mean, it's not donorship. I mean, it's investment into a global good. And I mean, I think we have to kind of reverse that thinking. I mean, and it is, as I said before, it's support, and it's support in both directions that I think is important. I think we have at the moment a window of opportunity I don't know, getting it straight or getting it right, but at least getting closer to that ideal system. And I mean, this has to do with sustainability, and this was already mentioned. We have at the moment, I mean, a plethora of resources is actually mobilized, but we all, I think, agree that this window of opportunity will close. I mean, just because resources are not endless, so we have to use them also to good effect. And I think, I mean, the best thing that we can do at the moment is, I mean, using, on one hand, the political visibility, but also the availability of resources to establish or transform structures. Because I mean, structures are sustainable. I mean, of course, we can fill the gaps, but I mean, if you establish structures, for example, as structures that combine the veterinary services with the human health services, at a how should I say, with a vision for the future. I mean, this is something that we can actually do at the moment, and this is what we should get at. And I mean, one of the concepts towards that is, for example, I mean, the closer interaction between, I mean, human health and veterinary health. I mean, we have a project here in the Global Health Protection Program, bridging international health regulations, which is the human side, with the performance on veterinary services, which is the animal side. So bring them together. I mean, they won't completely overlap, but at least they can be aligned so that we speak with the same language also in this particular aspect. And the last one, and I think we have been struggling with that for decades, if we really want to have sustainability, I mean, we have, at least to a certain extent, deviate from the project funding system. I mean, we've seen that before. We have a project that runs for 3 years, and then you go in and start establishing things, and then, I mean, you get perhaps a once extension, and then it's that moving in, moving out situation. And this is extremely frustrating in the end. I mean, because, I mean, at least many of the instances, I mean, you don't really get the sustainability that you were aiming at first. And I think, I mean, this is something that we also need to think about. And I'm particularly thankful also that, I mean, with an institutionalized resource as you got that, as we got, as some of the others here, I mean, we have a long-term vision, and we are not dependent like academia, I mean, sitting down and writing grants all the time, I mean, just to get the whole thing moving. And I think this would be something that I think is a vision for the future.
Yeah, thank you. And some very important points there again. So, John, I'm going to hand over to you for some closing remarks from your side, but there is a word cloud. So we did another, the audience, virtual and in the room, was asked, what do we need to do differently? It's actually the same question that we just answered. What do we need to do differently in global health partnerships? And I think we can get this up. Okay, so we need to give sharing knowledge and data ownership in the South, giving power to the global South. I think the sort of common themes that we've heard across the many valuable comments that you made, I think also here show up very clearly. So thank you for that. And I think with that, John, I'm going to hand back over to you for some remarks and reflections before we hand it back to the Ministry of Health.
No, wonderful. Thank you, Joanna, and also thank you for the opportunity to allow me join the panel. That was an opportunity that I wanted to request, so you don't need to apologize for that. I think this to me has been an exciting panel. I've learned a lot, taking down a lot of notes. But let me leave you with these reflections that I really like the theme of this session, which is the power of partnership. And nothing of good can actually happen in a world of pandemic response without the power of partnership. I think I really like that. However, we have to be very deliberate, as we are hearing from these conversations, that in every partnership, there are partners, so that the partners really feel that they are equals, that they are coming to the table to address a mutual interest that will be beneficial to everybody. And it can be done. We have seen over this crisis that, and I'll use some very specific example, and not to make the RKI look better than it is already, but the work we have been doing with RTI with co-creating a program has been remarkable, where it has taken weeks and weeks and months to co-create and think about what is it that the partnership can bring to bear, both for Africa CDC in the spirit of security, and then working together with the RTI. Everybody feels respected. Everybody feels like their views are heard and not neglected. I think those are the kind of partnerships that we mean when we refer to a new public health order for the continent, at least from the perspective that I'm working on. The thirdly is what I'm hearing is sustainable workforce development. The centrality of any good response is an effective, competent, C-based workforce development. And Toji mentioned that repeatedly, and I can't agree more. If you look at the continent of Africa, and I'll just use my position where I sit, there's a saying that you are standing on every issue is where you sit. So I'm sitting here in Africa, and I can only speak to that. We will need at least 6,000 epidemiologists, and we only have about 1,900 as a continent. So I think that sustaining that and building partnerships to address that unique gap is very important. I'm sure it will be the same in Latin America and other parts of the developing world. I mean, learning from each other, it doesn't require that you are in the global north or south. I think one of our panelists, I think that was Helena, talked about our rich experience in using community healthcare workers that have been extremely effective in our response. our ability to drive this response with national public health institutes. Good examples there to cite, including the Nigeria CDC and others, Ethiopian Public Health Institute. Those are all good examples that we believe can be sustained and would make for good partnership. One Health has been raised over and over. I can't agree more. I think this pandemic, in my view, has actually made global health global. Okay, it used to be that a definition of global health is where someone flies from the global north to south to address their issues of maybe meningitis, Ebola outbreak, or cholera. But now it is truly global. So it has flattened the curve. Not only are we trying to flatten the COVID curve, but it has flattened all of us, shown that we are very vulnerable and we thought we were, that we are more connected than we thought, and they, of course, expose the inequities. I think those are all issues that partnership will address. And lastly, that we have to think long-term. I mean, long-term meaning that we invest today for tomorrow. It means that we see, there's a saying that you don't dig your wells when you are thirsty. You dig your wells when you are not yet thirsty, so that the day you are thirsty, you use it. It means considering resources input into health system as truly an investment, not a cost. I think for all of us, regardless of whether you're in the global south or global north. So those are some of the things that I heard emerging from this very rich conversation. And Joanna, I'll let you have the last word and then bring this session to a close.
Thank you so much, John. And I think for me, it's just to thank everybody here, but really to thank you above all, but to hand it back to the Ministry of Health and Dr. Christoph Bayer, who will add his closing words. From my side, certainly already a big thank you to all involved.
Yeah, many thanks as well from my side. I don't want to extend this session, but just wanted to underline again that we are from the Ministry of Health really extremely grateful that you dedicated your time to share your experience and your knowledge with us. And just please allow me just to mention a couple of words which I think we can discuss days about it, and which will help us as well to further develop our global health protection programs, but also other programs where we are all working on the same goal and where we want to achieve the same global health. So Dr. Bino, you just mentioned the trusted networks at all levels, which has been built through this partnership, and all levels really regional and as well in a broader region, together strengthening the network with the Robert Koch Institutes and others. But it was very well taken that, or it was really noted that there's as well a lack in the clinical management. The public health was advanced very much, but clinical management, apparently there are some doubts. And then coming to Emma Iriarte Kakona, that you as well mentioned the value of the sub-regional networks. And when it comes to development of projects and programs, on the necessity of allowing feedback loops and not coming only with your own ideas. And yeah, of course, Dr. Nkanga Song, you mentioned as well this donor-driven agenda, where it's the concept of partnership, and that's what I think we all have the same goal. And I like very much your theater of response and your pandemic compass. Please allow me to use these words again. I like the pandemic compass, fantastic. Dr. Tocci, then again, you mentioned the IPC ships that already sailed in peace times, which is very important. And I think it's an IPC ship which was mainly built for AMR, but it works as well in a holistic world. And then what's very important is keeps the enthusiasm when it comes to human resource building. Yeah, Professor Elena Leganda, that the scientific policy nexus which you mentioned, and then we come to the issue of risk communication. I think this is one of the biggest issues we have as well in the lessons identified and then lesson to be learned, which is the risk communication, including the community to the community and the community health workers. And then Professor Messenreiter, I think multi-directional support and learning in the One Health sector. That's what I like, the One Health sector. Yeah, perfect. So thank you very much as well again from my side. Thank you very much again for your time. And I can assure all of you that we will take home at the ministry all these points. And I think that all of you hopefully will as well have some further ideas on how to go on with our joint and mutual aim and projects and programs while working together. So thank you very much, all of you, in particular to the panelists and to the chairs, and of course to the auditorium, and have a good evening.
Thank you. Thank you very much.
Thank you.